Hey everyone, and welcome. Today we're going to talk about something super common that millions of us deal with but don't always talk about: varicose veins. We're going to dive into the surgical options from the old school classics to the brand new tech that has completely changed the game. Let's get right into it. So, to get a sense of just how big a deal this is, check this out. The underlying issue, venous disease, is more common than coronary artery disease, peripheral arterial disease, heart failure, and stroke combined. No, you heard that right, combined. This is way more than just a cosmetic thing. It's a huge public health issue.
So what is a varicose vein anyway? Well, in simple terms, it's a vein near the surface of your skin that's stretched out to 3 millimeters or more. And the real problem is a 1-2 punch. First, the wall of the vein gets weak, and second, the tiny valves inside it start to fail. You know, those valves are supposed to be like little one-way doors, keeping blood flowing up to the heart. When those doors break, blood flows backward and pulls up, and that's what makes the vein bulge out.
And that failure isn't just about looks. It leads to some very real, very uncomfortable symptoms. We're talking about pain and swelling, that classic achy, heavy feeling in your legs. And if it gets worse, it can lead to clots, bleeding from those thin veins, and even serious skin issues like eczema or ulcers. Okay, so for more than 100 years, the main way to fix this was a procedure called high ligation and stripping. For a very, very long time, this was the undisputed gold standard for treating the main problem veins. Let's walk through how it works. First, the surgeon makes a small cut up in the groin and ties off the top of that faulty vein where it meets the deep system. That's the ligation. Next, they thread a thin, flexible wire, that's the stripper, all the way down the length of the vein. And for the final step, they tie the vein to that wire and physically pull the entire thing out of the leg. It's a very direct approach. If the plumbing is bad, you just remove it. Now, if that sounds a little intense, well, you're not wrong. Vein stripping definitely earned the reputation for a tough recovery. The source material even talks about the memory of large incisions, extensive bruising, significant pain, and prolonged disability. But here's the key. That memory is from a different time. Because today's vein stripping is a whole different animal. Seriously, modern tech has completely transformed it. Surgeons now use ultrasound to see exactly where to make tiny, precise cuts. They also inject something called tumescent anesthesia, which is a total game changer. It numbs the area and constricts the blood vessels, which means way, way less bleeding and bruising. The experience today is worlds apart from what it used to be. But then, in the 21st century, a revolutionary new challenger entered the ring: endovenous ablation, or EVA. And this less invasive approach completely changed the conversation. So what's the fundamental difference here? It's actually pretty simple. Stripping physically removes the vein from your body. Ablation, on the other hand, destroys it from the inside and leaves it in place. A tiny catheter goes into the vein and uses heat, either from a laser or radiofrequency, to basically seal it shut. Your body then just naturally absorbs the treated vein over time. And in the medical world, definitely took notice. This quote from the official clinical practice guidelines says it all. They flat out recommend thermal ablation over surgery for most people, and it's because of the easier recovery and less pain. It's now the go-to first-line treatment in most cases. So if ablation is the new favorite, how do these two really stack up against each other when you put them head-to-head in clinical trials? All right, let's get into the showdown. When it comes to the patient experience right after the procedure, the trials show a really clear winner. Post-op pain, bruising, recovery time, it's all significantly better with endovenous ablation. It's just a less traumatic event for your body, plain and simple. And this chart just puts a number on that difference. Look at this. One study looked at how long it took for people to get back to work. For the surgery group, it was almost 20 days. For the ablation group, just over 12. That's a full week sooner, which is a huge deal for pretty much anyone. But what about long-term? This is where it gets really fascinating. You'd think the new tech would be way more effective, but the data shows that their overall success rates are actually pretty much the same. The really interesting part is how they fail. With stripping, the big issue is something called neovascularization. Your body literally grows new, faulty veins. With ablation, the problem is recanalization, where the vein that was sealed shut manages to reopen itself. Okay, so since ablation has a much easier recovery and similar long-term results, you'd probably think surgery is dead and buried. But that's not the whole story. There are some very specific situations where the classic approach isn't just an option, it's actually the better choice.
So the big question is, should we go ahead and write the obituary for vein strain?
And the answer is a definite no. As you can see here, there are several key times when surgery is still the best option. For instance, if a vein is too close to the skin, using heat from ablation could risk a skin burn. If a vein is super large, really scarred up, or just too twisty to get a catheter through, well, in those cases, the straightforward physical removal of surgery is still the best and safest solution.
And that really brings us to the ultimate conclusion from all this. The modern treatment for varicose veins isn't about one method being universally best. The future is all about personalization. This quote from the source material absolutely nails it. There is no one-size-fits-all fix. A single person might even have different kinds of problem veins in the same leg that all need a different approach.
So the key takeaway is that a modern vein specialist comes to the table with a whole toolbox. They might use endovenous ablation for a long, straight vein, but then switch to a surgical technique like phlebectomy for the smaller, lunky branches, and maybe even use sclerotherapy injections for the tiny spider veins. It's about mixing and matching, using the right tool for the right job, all based on your specific anatomy. So this leaves us with one final crucial thought. The real debate isn't about old surgery versus new ablation. It's about making sure an expert is looking at your legs, your veins, your anatomy, and creating a plan just for you. So the most important question you can ask is this: is my treatment plan being designed for my specific veins? Thanks for watching.